Hi there, my valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I'm the founder of Progressive Pharmacotherapy Consultants, the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. At Progressive Pharmacotherapy Consultants, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, I would urge you to sit back and spare me part of your precious time to share some tips with you for high-impact pharmacotherapy services. So I welcome you to part 7 of our Pharmacotherapy MCQs. So let's get started with question number 1. You are reviewing and attending to a patient SOK who happens to be a 63-year-old male patient that has visited your cardiac clinic for his routine blood pressure follow-up. His past medical history involves hypertension and peripheral artery disease. He happens to be a smoker, and today his blood pressure is 133 systolic and 83 diastolic. He received an influenza vaccine 1 week ago at a neighboring clinic. He also received the PPSV23 pneumo and the meningococcal vaccines 2 years ago. So, with the information provided, what would be the best of the recommended immunizations for Mr. SOK today during this clinic visit, according to the CDC Advisory Committee on Immunization Practices, the ACIP? Would it be Hepatitis B vaccine, or would it be the meningococcal vaccine, or would you administer the zoster vaccine, or would you repeat another pneumonia vaccine? I'll give you 10 seconds to make the correct pharmacotherapeutic choice before displaying the answer that is correct in my opinion. So according to me, C is the correct answer. I would administer the zoster vaccine. Now, answer A, in my opinion, is wrong because hepatitis B vaccine isn't recommended in the absence of additional risk factors for the disease. It doesn't seem to have any. Answer B, to me, is wrong because meningococcal vaccine is indicated only once, and he has already received a shot of the same. And to me, answer C is the correct answer because this vaccine is recommended by the ACIP for patients with non-cardiovascular disease. Now, our patient SOK has PAD, peripheral artery disease, and he's above 60 years of age. Now, answer D to me is wrong because SOK received the pneumonia vaccine 2 years ago, and repeat immunization isn't yet indicated based on the ACIP recommendations. Now, I recommend you look for the recommendations and read through to get to understand where I am coming from. The next question: which of these antihypertensive medication combinations should high-risk hypertensive patients receive due to their ability to effectively reduce the risk of cardiovascular morbidity and mortality according to the outcomes of the accomplished study? Now, if you don't know about this study, I would recommend searching literature and getting to know what it entailed. Would the correct answer be lisinopril, co-administered with hydrochlorothiazide? Would it be B, amlodipine, co-administered with benazepril? Or would it be benazepril, co-administered with chlorthalidone? Or would it be amlodipine, co-administered with olmesartan, Benica? I'll give you 10 seconds to make the correct therapeutic choice. So, in my opinion, B is the correct answer. Amlodipine and benazepril. Answer A, in my opinion, is wrong. The accomplished study showed that a combination of benazepril plus amlodipine was more effective for reducing cardiovascular events and death than benazepril and hydrochlorothiazide in the high-risk patients who also had hypertension. Now, lisinopril co-administered with hydrochlorothiazide wasn't evaluated in the accomplished study at all. That makes answer A wrong, and it makes answer B correct, therefore. Now, answer C is incorrect. Benazepril plus chlorthalidone wasn't evaluated by the accomplished study. Neither was amlodipine plus olmesartan. So both C and D are wrong options in my opinion. Let's move to the next question, which reads, a 47-year-old female patient by the name JKG reports to your clinic for a 3-month follow-up visit for the management of her hypertension. Apart from being hypertensive, she has dyslipidemia and depression. She is currently taking hydrochlorothiazide at a dose of 25 milligrams orally in the morning, lisinopril at 40 milligrams orally daily, amlodipine at 10 milligrams orally daily, and during this visit, her blood pressure is 147 systolic, 95 diastolic, with a heart rate of 72 beats per minute. Now, among her lab results are potassium level of 4.0 millimoles per liter. Her serum creatinine is 1.25 milligrams per deciliter. So, with this provided information, which of the oral options listed below should be added to her current regimen of medication to help JKG achieve her goal BP according to the current guidelines for treating resistant hypertension? Is it hydralazine 10 milligrams administered every 8 hours orally? Or would it be spironolactone 12.5 milligrams administered in the morning? Or would it be diltiazem SR administered at a dose of 120 milligrams once a day? Or would you opt for atenolol 25 milligrams administered once daily? I'll give you 10 seconds to make the correct therapeutic choice before displaying my answer. So, in my opinion, Spironolactone 12.5 milligrams administered in the morning would be the correct choice. Now answer A is incorrect because JGK has a BP goal of below 130 systolic and 80 diastolic. She isn't currently at goal based on her today's BP readings, which were 147/95. Now, adding spironolactone is a more appropriate choice according to the current guidelines for the treatment of resistant hypertension. I would recommend you read through them again. Now, answer B is the correct choice because her BP goal should be 130/80. She's currently not at goal, and adding spironolactone at that dose is a more appropriate choice according to the guidelines. Now answers C and D are not the recommended options according to the guidelines, so I would settle for option B and administer 12.5 milligrams of spironolactone in the morning in addition to the other medications she's taking at the moment. So let's move to the next question, which reads, which of the following did the ACCORD trial demonstrate when it compared intensive therapy with standard therapy goals? Was it intensive therapy significantly reduced the incidence of cardiovascular events compared to standard therapy, or did it demonstrate that intensive therapy significantly decreased incidences of cardiovascular events compared with standard therapy, or did it demonstrate that intensive therapy didn't significantly increase these incidences of cardiovascular events compared to standard therapy? Or finally, did it demonstrate that intensive therapy didn't significantly reduce the incidence of cardiovascular events compared to standard therapy? I'll give you 10 seconds to choose from the options above. So in my opinion, D is the correct answer. Now in this ACCORD trial, intensive therapy with systolic blood pressure goal of less than 120 millimeters of mercury didn't significantly reduce incidences of cardiovascular events compared with the standard therapy where the systolic goal was below 140. The annual rate of primary outcome, that is a composite of non-fatal MI, non-fatal stroke, or death from cardiovascular diseases, was around 1.87% to be precise in the intensive therapy group and 2.09% in the standard group. So the p-value here was around equal to 0.20. Now, intensive therapy was associated with significantly higher rates of adverse events attributed to antihypertensive treatment than standard therapy. So here the values were 3.3% versus 1.3% with a p-value less than 0.001 according to the outcomes of the study. So in that case, D is correct. In this trial, the intensive therapy with an SBP goal of below 120 didn't significantly reduce the incidences of cardiovascular events compared to the standard therapy with an SBP goal of below 140, Now the annual rate of primary outcome composite, as I said earlier, corresponded to 1.87 in the intensive therapy versus 2.09% for the standard group. The p-value there was 0.2. So yeah, that makes answer or choice D correct. Let's move to the next question, which reads, in 2018, the ADA and the EASD published recommendations for the management of hyperglycemia in type 2 diabetic patients. In which of the following categories is a less stringent A1C goal of between 7.5 and 8 recommended by both the ADA and the European Association for the Study of Diabetes? Is it patients on fixed dose combination insulin products with a history of hypoglycemia? Is it patients with heart failure with reduced ejection fraction and a history of MI? Is it patients whose life expectancy exceeds 5 years? Or is it finally patients on monotherapy diabetes mellitus treatment? I'll give you 10 seconds to make the correct choice. So in my opinion, the correct answer is B. Patients with HFrEF and a history of myocardial infarction. Now, answer A is incorrect because the 2018 recommendations called for less stringent A1C goals in patients with type 2 diabetes and a history of severe hyperglycemia with limited life expectancy, where limited here means less than 5 years, with advanced complications, or those with extensive comorbid conditions, or those with the difficulty of attaining the goals despite maximum combination, and I underline combination therapy, who have also received counseling. Now, answer B is the correct one because it meets those conditions. Answer C is incorrect because limited life expectancy refers to less than 5 years, not exceeding 5 years like in this case of C. And answer D is incorrect because patients receiving monotherapy for type 2 diabetes have not been maximized. They should be added medication before we finally declare treatment has failed. You have to maximize them. Let's move to the next question, which reads, in which of the following populations listed below is the use of eicosapentaenoic acid ethyl ester likely to reduce cardiovascular morbidity and mortality, according to the results of the REDUCE-IT study, the REDUCE-IT study. Now, I also recommend you visit the internet and read about this study. Is it patients with a history of myocardial infarction? Is it heart failure patients? Is it chronic kidney disease patients? Or is it hypertensive patients? I'll give you 10 seconds to make the correct pharmacotherapeutic choice. So A is the correct answer. It should be patients with a history of MI. Answer A is correct. Now, this particular randomized placebo-controlled study of the impact of that ester on the first major atherosclerotic events, which included cardiovascular death, non-fetal MI, non-fetal stroke, coronary revascularization, unstable angina, patients with established cardiovascular disease, those with a history of MI, for example, or with diabetes mellitus plus other risk factors were enrolled. So compared with placebo, the incidence of a first major atherosclerotic event was significantly reduced among those who received this ester. So that makes answers B, C, and D wrong, because the target population wasn't patients with heart failure, with chronic kidney disease, or with hypertension alone. Let's move to the next question. According to the American Diabetic Association, what is the minimum frequency recommended for self-monitoring of blood glucose SMBG in diabetic patients receiving multiple shots of insulin injection daily? Is it once a day, twice a day, thrice a day, or 5 times a day? I'll give you 10 seconds to make the correct choice. So the correct answer is 3 times daily. Now the ADA recommends testing SMBG values at least thrice daily in patients receiving more than 1 injection of insulin on any given day. So let's move to the next question, which reads, based on the 2018 American College of Cardiology stroke the American Heart Association guidelines on the management of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults, which of these patients should be treated with the so-called PCSK9 inhibitor? Is it a patient with a known atherosclerotic cardiovascular disease on maximally tolerated statin therapy with a 50% reduction in the LDL cholesterol and no previous use of lipid-lowering therapies other than statins? Or is it a patient with a baseline LDL of 160 and no known atherosclerotic cardiovascular disease who is intolerant to one statin? Or is it a patient with known atherosclerotic cardiovascular disease on maximally tolerated statin therapy plus ezetimibe with a less than 50% reduction in LDL cholesterol? Or finally, is it a patient with heart failure with maximally tolerated statin with an LDL of 130? So I'll give you 10 seconds to make a choice. So the correct answer here is C. Now answer A is incorrect because the guidelines recommend the use of PCSK9 inhibitors for secondary prevention of cardiovascular events in patients on maximally tolerated statin therapy with clinical ASCVD who don't achieve a 50% reduction in LDL or who have an LDL above or greater than 70 milligrams per deciliter. Now, ezetimibe is preferred over the PCSK inhibitors in the patient population cited in this answer with a PCSK9 inhibitor added as a third agent after you've already put the patient on a statin plus ezetimibe. So it is wrong. It's a wrong choice because at this level, the patient hasn't tried ezetimibe. Now, answer B is incorrect as well, because according to the guidelines, adding ezetimibe or a PCSK9 inhibitor to a maximally tolerated statin therapy can be considered for patients with a baseline LDL of 190 or higher and no ASCVD. A patient with intolerance to one statin should try another statin before we give up, before adding on ezetimibe or any other therapy. So answer C is correct because of the explanation I offered above. And answer D to me looks incorrect. The guidelines include no recommendations whatsoever for the use of PCSK inhibitors in the heart failure population. It's not mentioned at all. So let's move to the next question, which reads, CPJ, a 61-year-old female patient, comes to your clinic for treatment today. She has a past medical history of hypertension, diabetes mellitus, and chronic kidney disease. The albumin to creatinine ratio today is 40 milligrams per gram, and her estimated GFR is 65. And so according to the KDIGO, the 2017 KDIGO guidelines, and the patient's albumin to creatinine ratio, how can you describe or classify her eGFR and her proteinuria in this today's clinic visit? Is it a normal eGFR and a no proteinuria? Is it mildly decreased eGFR and moderately increased proteinuria? Or is it mildly decreased eGFR and no proteinuria at all? Or is it moderately decreased eGFR and moderately increased proteinuria? I'll give you 10 seconds to make a choice. So this patient in today's appointment has mildly decreased eGFR and moderately increased proteinuria. That makes answer B correct. Answer A is incorrect because her eGFR of 65 can be classified as mildly decreased, and her albumin to creatinine ratio of 40 is classified as moderately increased proteinuria. So that makes our answer B correct and answer A wrong. Now answer C is wrong because though the eGFR is mildly decreased, she does have a moderately increased proteinuria. So it's wrong to declare that she has no proteinuria. And answer D is wrong because her eGFR is not moderately decreased but mildly decreased. Let's move to the next question, which reads, LAM is a 65-year-old male patient who presents to your clinic with an NSTEMI and is taken to your cath lab, which has ability to do PCIs. In today's visit, LAM weighs 83.5 kilos and this gentleman is 5 feet feet 10. On obtaining arterial access, IV tyrosine was initiated. So, my question to you is, which anticoagulant would be the best option for LAM at this time? Would you administer Enoxaparin? Would you administer Bivalirudin? Would you administer unfractionated heparin? Or would you opt for fondaparinux? I'll give you 10 seconds to make the correct therapeutic choice. So answer C, unfractionated heparin, is the correct choice. Answer A is wrong. Enoxaparin is inappropriate and has been associated with increased major bleeding when compared with unfractionated heparin, especially in patients with NSTEMI who are managed invasively in the cath lab with cardiac catheterization. Now, answer B is also incorrect as well. Bivalirudin isn't appropriate because in the ACUITY, the ACUITRY trial, there was a suggestion of worsening ischemic endpoints in patients with acute coronary syndrome who received Bivalirudin compared to unfractionated heparin. That makes it a wrong option. So answer C is correct because of the explanation that in the 2014 ACC and AHA guideline for the management of patients with non-ST elevation acute coronary syndromes, unfractionated heparin is recommended for patients receiving glycoprotein 2B 3A inhibitors, and tyrosine is an example of those. Now answer D to me is incorrect. Now we know that fondaparinux should not be used as a sole anticoagulant because of the risk of catheter thrombosis according to the same guidelines above, the 2014 ACC AHA guidelines. I would recommend you read through them and get to digest the contents or the outcome. Let's move to the next question. So the same patient. My question to you this time round is, which of the following would be the most ideal dual antiplatelet therapy for Mr. LAM upon discharge from your hospital after he has recovered? Would you send him home on aspirin 325 milligrams orally once a day plus ticagrelor 90 milligrams orally twice a day? Or would you send him home on 81 milligrams of aspirin once a day plus ticagrelor 60 milligrams orally twice a day? Or would you send him home on 325 milligrams of aspirin once daily plus prasugrel 5 milligrams orally once a day? Or would you send him home on aspirin 81 milligrams alongside clopidogrel 75 milligrams, both administered once a day orally? I'll give you 10 seconds to make the correct choice. So I would opt for answer D. Now answer A is wrong because the recommended daily aspirin dose on discharge with the ticagrelor is 81 after PCI and not 325 milligrams. Answer B is wrong as well because the recommended ticagrelor dose alongside the 81 milligrams of aspirin is 90 milligrams taken orally twice daily, not 60. That would be an underdose. And answer C, in my opinion, is wrong because the correct prasugrel dose would be 10 milligrams once a day. Remember, this patient weighs 83.5 kilograms and he's 65 years old. So 5 would be on the lower side. So answer D is consistent with the recommendations in the 2014 ACC AHA guidelines for the management of patients with non-ST elevation acute coronary syndromes. Let's move to the next question, which reads, AWK is a 62-year-old lady with a past medical history of CAD, type 2 diabetes mellitus, and hyperlipidemia. Now, on admission to your hospital, her condition deteriorated. She underwent PCI and received a drug-eluting stent in the left anterior descending artery for the management of a STEMI that she suffered during that visit. So after the PCI was done, her ejection fraction fell. It's now 25%. So I would like you to choose the most appropriate duration of DAPT, dual antiplatelet therapy, for Madam AWK from the 4 options listed below. Would you do dual antiplatelet therapy for 1 month, for 6 months, for a whole year, or for 30 months? I'll give you 10 seconds to make the correct choice. So in my opinion, D is the correct answer. Now, answers A and B are incorrect because according to the 2014 ACC AHA non-ST segment acute coronary syndromes guidelines, and according to the 2011 ACC and AHA, alongside the Society of Cardiovascular Angiography and Intervention PCI guidelines, dual antiplatelet therapy with aspirin in combination with a P2Y12 inhibitor such as prasugrel, clopidogrel, or ticagrelor is recommended for at least 1 year. That's a class 1 level B evidence. So that makes 30 days incorrect. Now option B, which is half a year, to me is also incorrect because Madam AWK has what we call a DAPT score of 4 based on the fact that she's diabetic, she's had an MI, there's a reduced ejection fraction. So this suggests that the risk of recurrent thrombotic events is higher than the risk of a major bleeding when you do dual antiplatelet therapy for this particular madam. So she would benefit from prolonged dual antiplatelet therapy beyond 12 months, not just 12 months. So for this same reason, answer D is correct and answer C is wrong in my opinion. So let's move to the next question, which reads, how would you accurately describe the impact of continuing to smoke cigarettes after an episode of myocardial infarction? Would it be A, continued smoking post-MI negatively impacts only angina-related quality of life? Or would it be continued smoking post-MI negatively impacts health-related quality of life? Or would it be continued smoking post-MI doesn't negatively impact health-related quality of life? Or finally, would it be D, continued smoking post-MI positively in fact impacts only angina-related quality of life? I'll give you 10 seconds to make the correct choice. In my opinion, B is the correct answer. So patients who continue to smoke, that is cigarettes, after MI tend to experience worse overall health-related quality of life and more angina compared with those who stop smoking completely post-MI. Let's move to the next question, which reads, RMM is a 56-year-old male patient who presents to your clinic for further management of his unbearable osteoarthritic pain. He suffers from osteoarthritis and has CAD and is currently on acetaminophen, which he takes between 500 and 1000 milligrams orally every 6 hours to manage the pain. He also takes amlodipine 5 milligrams orally to manage the cardiovascular disease. He is also on statin, atorvastatin, which he takes 40 milligrams at night. And today, during this appointment, he denies optimal pain management for the past 3 months. He's been in pain. Acetaminophen hasn't been able to contain his suffering. So, which of the following would be the best substitute for his acetaminophen for his pain at the moment? Would you switch to naproxene sodium 220 milligrams orally twice a day? Or would you introduce celecoxib at a dose of 200 milligrams orally taken every 12 hours? Or would you administer any of the 3 choices of diclofenac, either 75 milligrams SR twice daily, or 50 milligrams of the ordinary tablets taken every 8 hours? Or would you opt for the 100 milligram SR once a day? Or finally, would you settle for ibuprofen 600 milligrams taken every 8 hours orally after food? So I'll give you 10 seconds to make choice. So in my opinion, I would pick on A as the correct answer and administer naproxene 220 milligrams orally every 12 hours instead of the acetaminophen. Now, in my opinion, that is the most appropriate. Now, population-based studies evaluating the influence of NSAID type and dosage on cardiovascular outcomes suggest that low-dose naproxene, which is 500 milligrams or less in any given day, is associated with a smaller risk for adverse cardiovascular outcomes than the other NSAIDs, such as ibuprofen, diclofenac. Now, the precision trial, to be specific, demonstrated that celecoxib at a dose of 100 milligrams was non-inferior to naproxene and ibuprofen with regards to cardiovascular safety, with fewer adverse effects. But the naproxene dose used in this particular precision trial was 375 and not the 220 that you're seeing up there. So making naproxene making a choice to give naproxene 220 milligrams twice daily would be the most appropriate NSAID regimen for him at this particular moment. Now, I disagree with answer B, celecoxib 200 milligrams orally every 12 hours, because in the trial, the precision trial, the celecoxib dose was 100 and not 200, taken twice daily after food. Now, answer C, in my opinion, is incorrect, because current data suggests that diclofenac use is associated with increased risk of MI compared to ibuprofen, to naproxene, and all other NSAIDs. So I would not opt for diclofenac at all. Now, answer D is also incorrect, because ibuprofen at a dose of 600 to 800 milligrams taken orally thrice daily is usually associated with more GI adverse events, more renal events, more hospitalizations for hypertension compared with the celecoxib, which was tested at a dose of 100 milligrams twice daily in the precision trial. Now, population-based data suggests that doses of ibuprofen above 1,200 milligrams a day are associated with increased risk of MI compared with the low-dose ibuprofen, which is below 1,200 milligrams daily. So I would settle for option A. Let's move to the next question, which reads, which of the following would be the best pharmacotherapy plan for GAO, who has a history of depression and stroke? Madam GAO currently takes fluoxetine at a dose of 40 milligrams in the morning to avoid interfering in their sleep, and she now requires DAPT, dual antiplatelet therapy, with aspirin 81 milligrams orally once a day, alongside clopidogrel 75 milligrams orally once a day, after she underwent a PCI where a stent was placed. Would you substitute clopidogrel with prasugrel, or would you decrease the fluoxetine dose by half to 20 milligrams in the morning, or would you double the clopidogrel dose to 150 milligrams orally once a day, or would you substitute fluoxetine with citalopram at a dose of 10 milligrams once a day? I'll give you 10 seconds to make the correct therapeutic choice. Opinion D is the correct answer. I would knock off fluoxetine and introduce citalopram. Now, A is incorrect because prasugrel isn't recommended for patients who have had a previous stroke for obvious reasons. Answer B is incorrect because fluoxetine is known to be a CYP2C19 inhibitor. Now, this would inhibit the activation of clopidogrel, which happens to be a prodrug, to its active form. It has to undergo a two-stage conversion to become active. Now, reducing the fluoxetine dose isn't a recommended strategy in managing this major drug-drug interaction. Even if you reduce that dose, the clopidogrel would remain inactive, so there would be risks of thrombosis in this particular case. Now, answer C is incorrect as well. Even if you double the clopidogrel dose, its activation would still be inhibited by this strong CYP2C19 inhibitor, which happens to be our antidepressant fluoxetine. So, in my opinion, D would be the correct option. Changing from fluoxetine to citalopram would be the best choice for Madam GAO, because we don't recommend co-administration of fluoxetine and clopidogrel. which happens to be an inactive prodrug. Now, this switch avoids that drug-drug interaction, and therefore the CYP enzymes would activate our preferred antiplatelet clopidogrel through a two-step process, and we would not have a case of thrombosis when we co-administer clopidogrel alongside citalopram instead of the fluoxetine, and her depression would also be managed optimally. So let's move to the next question, which reads, M.O.M. is a 68-year-old white male employee of the U.S. Embassy in Kampala, Uganda, who was admitted at the Aga Khan University Hospital in Nairobi with an end STEMI. Now, Mr. M.O.M. underwent a PCI in the cath lab at the Aga Khan and received a DES, a drug-eluting stent, in his left circumflex artery. He has a past medical history of a permanent AFib, type 2 diabetes mellitus, and hypertension. His creatinine clearance is 65. So, my question to you, or my task to you, is to select the most ideal oral antithrombotic regimen for Mr. M.O.M. from the 4 options listed below. Would you opt for 81 milligrams of aspirin plus 10 milligrams of prasugrel, both taken once a day? Would you opt for 60 milligrams of edoxaban, taken once a day, 81 milligrams of aspirin, taken once a day, and 75 milligrams of clopidogrel once a day? Or would you opt for 15 milligrams of rivaroxaban, co-administered with 75 milligrams of clopidogrel, both taken once a day? Or finally, would you settle for warfarin plus 81 milligrams of aspirin plus 90 milligrams of ticagrelor, taken twice a day? I'll give you 10 seconds to make the correct pharmacotherapeutic decision for Mr. M.O.M. In my opinion, C is the correct option. I would settle for rivaroxaban 15 milligrams orally once a day plus clopidogrel 75 milligrams orally once a day. Now, in my opinion, A is wrong because this patient's Church-Vask score is 4 from a quick computation based on his age, history of type 2 diabetes mellitus, and hypertension. He requires anticoagulation in addition to the antiplatelet therapy for this particular end STEMI. Now, answer B as well is incorrect. I'll refer you to the Pioneer AF PCI trial. Now, in this trial, patients who had recently undergone PCI with stent placement and who required anticoagulation for AFib were randomly assigned to 3 groups. There are those who received rivaroxaban 15 milligrams orally once a day plus a P2Y12 inhibitor. There are those who received 2.5 milligrams rivaroxaban twice daily plus dual antiplatelet therapy. And in the 3rd group, standard therapy with warfarin plus dual antiplatelet therapy was offered. Now, the incidences of clinically significant bleeding were significantly lower in the 2 groups that received rivaroxaban compared to the standard. So the values were 16.8% versus 18% versus 26.7% in the standard group. And the p-values were less than 0.001 in these cases. So at this time, data are lacking to support the use of Enoxaparin with the dual antiplatelet therapy following STEMI. It's not quoted in literature, so that makes answer B incorrect. Now, answer C to me is correct according to the Pioneer AFPCI trial. That is PIONEER AF-PCI trial. Because of the explanation I've offered above, this makes the right choice for Mr. MOM. I would settle for 15 milligrams rivaroxaban, clopidogrel 75. That's the best choice for him. Now, answer D to me looks incorrect. Consensus recommendations for antithrombotic therapy for patients with AFib who require PCI for an acute coronary syndrome currently recommend DOACs instead of warfarin, and clopidogrel is the preferred P2Y12 inhibitor in this scenario. So triple therapy, triple antiplatelet therapy isn't recommended, especially with warfarin and ticagrelor when given with aspirin. So that makes choice D inappropriate. Let's move to the next question. UMK is a 44-year-old male patient who was diagnosed with NSTEMI 1 month ago, after which a PCI was done with stenting. Now, UMK was discharged on appropriate medical therapy, and today he presents to your cardiology clinic complaining of depression for the past 1 month after he quit smoking. He misses his Dunhill and Winston, that were his favorite brands, and he now fears that he might relapse back to those bad old habits. So my question to you is, which smoking cessation therapies listed below would be the best or the most appropriate for Mr. UMK to avoid him relapsing back to smoking, bearing in mind that he's at risk? He has had a PCI because of an NSTEMI. Would you settle for nicotine patch? Would you recommend varenicline for him? Or would you opt for Zyban? Or D, would you opt for clonidine? I'll give you 10 seconds to make the correct therapeutic choice. So in my opinion, C is the correct answer. Now, A is incorrect. A nicotine patch alone isn't the best choice for such a patient, because normally combination nicotine replacement therapy is more effective than just a single one, and we should first attempt dual therapy of either a gum plus the patch before settling for the patch alone. Now, answer B to me is incorrect, because varenicline carries a warning in literature about neuropsychiatric adverse events, and depression is also quoted there. And remember, our patient is already depressed after quitting smoking, so this would be a no-no. Answer C is correct. It can assist in the management of both depression and cigarette smoking cessation. So you would kill two birds with one stone. And answer D to me is incorrect. Now, in literature, clonidine is referred to as second-line agent for smoking cessation. At this time, I think the best option for a patient would be a first-line choice. So clonidine would not be the drug of choice. I would not prefer it. I would attempt to use it after the first choice fails. Let's move to the next question. So my esteemed viewers and listeners, that brings us to the end of part 7 of our pharmacotherapy MCQs. If this video helped you in any way, I would like to urge you to remember to give it a thumbs up and to subscribe to my YouTube channel. I promise you, the best is yet to come. Thank you for viewing and for listening. I hope to interact with you in part 8 of this series. Thank you for your attention.